any data on the changing prevalence? Is it really a constant prevalence and change in the population?
Exactly right. That's right. Yep, absolutely. Yeah. Yep. So the prevalence data all suggests that the rates of depression have remained the same. It is population ageing that's causing the increase. Yep.
So the one that you showed us, which showed the lines going up and down in the rank,
yeah.
is that available in I'm just interested in what the absolute terms, because you see this is going down, but it may not be in real terms. It's being unmasked by other things that have really gone down. Is that known? What without ranks? Well, you look at it and say, oh, major depression there has gone.
Yeah, in absolute terms. Yeah.
Not really changed.
Yeah. Yeah. Well, you can look at the prevalence rates.
Yeah.
So all of the data that's behind the burden of disease is available online. So you can search for depression in Australia in 15 to 19-year-olds. You can get that as a spreadsheet.
Yeah, I mean, it would almost be interesting to see it with gaps left blank when things drop out but don't move. Because, of course, if you solve the things that kill children, things that kill adults move up in the ranking even if their prevalence doesn't increase.
Yeah.
And so you can't, I mean, yes, of course they've increased because you've solved your other problems, they're not actually becoming more common. So it would be interesting to see if you could show that ranking but allow things to leave the chart entirely rather than just be replaced by things that naturally become more common.
Yeah. How much time do we have left? By the way, if you have questions, like this might as well be a question and answer time as well.
How did they deal with, or who decided how to deal with proximal and distal causes?
So, give me.
So, for example, cirrhosis is a cause of death rather than chronic viral hepatitis, which is the cause of the majority of cirrhosis. But HIV is a cause of death rather than TB, which causes the majority of HIV deaths. So in the case of people who die with HIV, HIV is treated as the cause of death, even though it's the distal cause to the infectious disease which actually killed them. But in the case of cirrhosis, it's treated as the ultimate cause, not the chronic viral hepatitis that caused the cirrhosis. Do you see what I mean?
Right.
So in the case of people who die with HIV, they're saying that the HIV killed them. But in the case of people who die with liver cancer, they're not saying that the chronic viral hepatitis killed them.
Right.
So what's... It seems strange that those two things are treated inconsistently. It seems like you should go either with the ultimate cause of death in all of the cases or the significant distal cause in all of the cases. But to chop and change seems strange. Yeah,
I mean, the principle, as far as I know, so I worked on the disability side more than the mortality side, but the principle, as far as I know, is that it's the underlying cause of death that should be from the certification of the cause of death that should be attributed to the death should be attributed to the underlying cause. But I'm not sure in those examples. I'm not sure why they would change.
Well, that's the underlying nub of the issue you identified being the triple counting, isn't it?
Yeah. So you have to count a death only once.
Their disease.
That's right.
Interest
yeah.
And yet the same thing, I think, with cost. I hate all these access economics reports in Australia. Someone should add all them together, and I'm sure there'll be many times with the value of the economy. Because they all count.
Yeah.
They ignore all the comorbidity and
that's right. Yeah.
Counting over and over.
And that's one of the huge benefits of the burden of disease studies, that everything has to fit within one mortality envelope, right? Like there's a limited number of deaths in the world.
But you lose so much when you do that. Like it's, like with the HIV TB thing, because everybody talks about HIV, and it's like, yes, but they're...
So HIV, there's HIV, TB separately in the burden of disease. I mean, what is it? Where is it?
Well, it's interesting that it's counted together. It's interesting that they're kept together in that graph, but then when you split them... Yeah. Oh, so this is just, aggregating at for kind of ease of policy, or for policymakers. Yeah, but it's just when the cause is shared. Like a quarter of TB deaths happen in people who have HIV. The majority of HIV deaths happen in people who have TB. So it doesn't make sense to split them. You can't split those people who are in the middle, who overlap and who are co-infected.
Right.
They die because they have both.
Right.
You know,
Interesting.
and you
Yeah.
just can't.
Yeah.
It doesn't mean anything unless you separate them. Like it just doesn't. There's no rational way of counting them and treating them separately. And the same with advanced liver disease and chronic viral hepatitis. It doesn't. You know, to say that they died of liver cancer, well, yes, they did, but they only had liver cancer because they had chronic viral hepatitis. So again, you just can't. Yeah, there are things that it doesn't make sense to talk about a single cause of death.
Yeah. True.
So it's,
There's a couple of other things that I could talk about, unless people have more questions. But there's a really good summary, a really good infographic that the Lancet produced, and hopefully the audio will work. Oops. Okay. So let's play this. Okay, there's no audio. So,
Do you unplug the audio from your computer? Go to the computer?
yeah.
291 disease causes. This new report builds on GBD 2010 to focus on mental health, presenting the burden of mental and substance use disorders in 1990 and 2010. In GBD 2010, worldwide mental and substance use disorders accounted for 7.4% of total disease burden, making mental health and substance use disorders the fifth leading disorder category of DALYs. DALYs are disability-adjusted life years, the number of years lost to illness, disability or early death. One DALY is thought of as one lost year of healthy life. This study shows 183.9 million DALYs worldwide for mental and substance use disorders. This includes 8.6 million years of life lost and 175.3 million years lived with disability. The highest proportion of DALYs occur to those aged 10 to 29. Depressive disorders have the highest proportion of total burden across all regions, followed by anxiety and drug and alcohol disorders. The GBD 2010 results for 1990 and 2010 show the total burden of mental and substance use disorders increased from 133.6 million DALYs in 1990 to 183.9 million, a rise of 37.6%.
So this is what we were talking about earlier.
This increase is explained largely by population growth and aging, while the way results were combined masked some disorder-specific differences. For example, the prevalence of alcohol, opioid and cocaine dependence increased between 1990 and 2010, whereas the prevalence of most mental disorders did not. Reducing the global burden can't be done without political and professional commitment. We need a global effort to implement cost-effective prevention and intervention strategies, and to develop innovative ways to deliver these to the population.
So I thought that was a really nice infographic that kind of summarises some of the results for the mental and behavioural disorders. And the last thing I kind of want to talk about is this idea that that research isn't enough, that it's not enough to publish a study like the Global Burden of Disease in a journal like The Lancet. There's been a huge amount of resources in terms of investment and time that's been put into this study, and to just publish it in a journal and hope for kind of trickle-down effect, kind of like trickle-down economics, I just don't think is enough. So I think there really needs to be a focus on translating research into policy, and for people to communicate, once they've done a study like the burden of disease, to communicate the findings, to facilitate policymakers implementing some, or at least guiding policy using some of the evidence that's been collated. there's a push towards this at high levels. So the WHO Director General said that there's a gap between today's scientific advances and application, between what we know and what's being done. And health work teaches us that action without knowledge is wasted effort, just as knowledge without action is wasted resource. Bridging the gap between knowledge and action is one of the most important challenges, WHO, and the greatest opportunity for strengthening health systems. The Secretary of Health for the Department of Health and Ageing said at the launch of the GBD that having the work known and understood in an academic context isn't enough. It's getting the word out so it's used in a meaningful way to deliver the outcomes to the people that we're trying to provide service to. I like this. So with the GBD, there's kind of a parallel with what economists use to guide policy. In a way, the GBD is the health version of this. As it becomes a regular publication, it will be the kind of thing you refer to. What's my health account like? How am I going? What should I be investing in? This marks a point of departure from talking about mortality, which really has been driving the conversation for a lot of the last 20 years. But now we're talking about not only mortality, but how to keep people alive and healthy. It also allows you to move away from a situation where if you had a fantastic advocacy machine, you got the money. This kind of levels the playing field. It gives voice to those who are actually in need and resources that we need to allocate. I really like this quote from Richard Horton via Pericles. What you leave behind is not what is engraved in stone monuments, but what is woven into the lives of others. So, a little uplifting note to finish on. Any questions?
Is there going to be an Australian burden, disease and injury study separately as there's been in the past, or will this take it over now?
In an ideal world, it should be done in concert because the infrastructure and the networks that have been set up is set up to really be on a global scale. And if you start kind of separating out the methodology, then you start losing the comparability. Like, what does it mean if an Australian burden of disease study says they come up with this number versus this number over here?
Might want to call the AHW because they're about to get started.
Well, yes, they are about to get started.
They're just about to redo their 2007
Yes, but in collaboration with the global burden of disease. Yeah.
So will they be consistent or not?
If it's done in collaboration, absolutely. Yeah.
So are you using some of this research in policy?
Not me personally, but that's the ultimate goal.
Yeah.
I mean, I've been talking with policymakers in the Philippines, about to go to Fiji to talk with some policymakers there, and disseminate the results and demonstrate the utility of something like this. So hopefully it gets picked up. At the launch of the burden of disease earlier this year, Jane Holton was there, and so was her principal advisor. And he said, policymakers just don't have time to digest full-length journal articles. You may get kind of 30 seconds with a policymaker in a lift. You've got to have a 30-second speech ready. What's the importance? Why do you need to spend some time looking at this? And he said because the status quo is dominant. Which I thought was really interesting.
To have a conversation in the school for those interested in mental health. Now we have a Centre for Mental Health about the policy implications of the mental health data in Australia, because your assumption is prevalence hasn't changed. That would be my assumption too. So what should we be doing? A lot has gone into services. There's no population benefit as far as you can see from that. So it'd be interesting to see suicide in Australia, because I think that suicide Australia probably has done well compared to some other countries in that regard. What would we make of it, or what would we do differently?
Excellent questions. Yeah, absolutely. I think that would be a really interesting discussion.
Discuss it with people.
Yeah.
Because this is terribly important, because I remember old document when the first global burden of disease came out. The emphasis on depression, like with the creation of Beyond Blue, was really largely attributed to that study.
Right, yeah, that's right.
People really didn't take much note. They were driven by the mortality figures and the hospitalisation figures, and when that came out and the emphasis on disability and the high prevalence disorders, people began to take much more notice of them.
Yeah, that's right. Yeah. Yeah, there really has been a huge shift in the conversation. Yeah. And I think that will continue. I think the one of the worrying things is the kind of the double burden that countries are now experiencing. So you've got kind of the communicable diseases, but you've got also rising non-communicable diseases. So, you know, in countries that that haven't adequately kind of tackled the communicable causes, and that kind of the non-communicable causes are coming online.
And they interact. I mean,
yeah,
diabetes
absolutely.
in the Pacific is exacerbating their TB problem.
Right.
You know, so they're just not, again, you get this interplay where the rising prevalence of diabetes is going to have a negative impact on communicable disease as well.
I think it would be interesting to try and link this literature. I did this review earlier this year of studies on global well-being, and there's a whole social science literature on that, all based around surveys asking simple questions about happiness and life satisfaction. And a lot of it's driven by economics, so people are looking at GDP per capita, which seems to be an important driver, and they're looking at, what should a country do?
Yeah, the gross national happiness index.
With this literature at all. It's very, in fact, very seldom do they have health indicators in it.
Yeah, that's right.
And there would be a lot that could be done to try and link the two.
Yeah. Yeah, that's an interesting question. So I previously, some of my PhD was on well-being in particular. And there's a distinction between objective and subjective well-being. So objective well-being typically is, how much money do you have and what's your kind of life circumstances like. But correlates poorly with subjective well-being. So you might have objectively good life circumstances, but you can have pretty shitty subjective well-being. And moreover, what are they called? Ratings by family and friends don't correlate very well to your own self-ratings. And so, but back to the burden of disease, it was very explicit that there's no well-being